And now for our next session, putting it all together, how we identify the causes of anorectal symptoms. And our first lecturer is Dr. Natalia Zarate, who's a consultant gastroenterologist from University College Hospital in London. She's going to be talking about identifying the causes of symptoms, phenotypic variation in fecal incontinence.
Hello, I would like to first start thanking the organizers for inviting me to give this presentation on phenotypic variation in fecal incontinence. As you know, the prevalence of fecal incontinence in the general population is high, but this is particularly so for women over the age of 40 who are disproportionately affected because of pelvic floor dysfunction due to childbirth. The prevalence increases with age, and it is estimated that 50% of nursing home residents and around 80% of those with severe cognitive impairment experience bowel leakage. Fecal incontinence etiology is multifactorial. This is a complex condition. There are non-GI related factors like mobility, for example, the ability to reach the toilet on time, mental faculties that are required for identifying the presence of stools in the rectum and coordinating defecation. There are gastrointestinal suprasphincteric factors like stool consistency or colonic motility. Increased colonic motility can cause urgency diarrhea, and reduced colonic motility can cause fecal impaction. Rectal sensory motor function is crucial for continence. The ability of the rectum to sense the presence of stools and increase and the abdominal pressure facilitating evacuation. And the functional and anatomical integrity of the sphincteric complex in the anal canal is also fundamental. As mentioned before, risk of fecal incontinence increases with age. Parity is a fundamental factor, and there's an increased risk for patients with a history of pelvic surgery or anal surgery. Upon following appropriate clinical history taking, a physical examination, including digital rectal examination, management of fecal incontinence can be initiated in primary care with dietetic modifications and initiating pharmacological interventions. But if symptoms persist, the decision regarding implementing more complex therapeutic options requires appropriate assessment of the mechanisms that are contributing to fecal incontinence. So, as mentioned before, it is important to establish the clinical history and the symptoms characteristics that is going to influence the investigations to be performed and help to characterize the mechanisms contributing to fecal incontinence. One important aspect for this condition is that there is not an agreed algorithm to investigate the condition, and this makes very difficult having a standardized approach to the condition. We can establish a distinction between those patients who have isolated fecal incontinence in the form of urge or passive incontinence and those who have fecal incontinence with a coexistent constipation due to either an evacuatory disorder or due to fecal impaction leading to overflow. High-resolution anorectal manometry is considered a fundamental test investigating symptoms of fecal incontinence. A panel of experts recently agreed on a protocol, on a standard protocol that should help in improving the knowledge of this condition through implementation of this standard and agreed protocol at different institutions. This protocol allows investigating of both continence and evacuation and also sensory function of the anorectum. The London Classification has also led to emerging new concepts. And when the anal resting pressure is below the lower limit of normal, the patient will be the case will be defined as having anal hypotension. If the anal squeeze pressure is below the lower limit of normal, then that would lead to a definition of anal hypocontractility. This slide shows on the lower part of the slide 2 examples of high-resolution anorectal manometry recordings. We have on the left-hand side reduced resting pressure in a patient with passive incontinence and therefore with a diagnosis of anal hypotension. And on the picture on the right-hand side, reduced squeeze and sustained pressure, so that is anal hypocontractility in a patient presenting with urge incontinence. But as mentioned before, symptoms are poorly correlated with the outcome of investigations. And effectively, the Fielding group in Australia found a weak correlation between the severity of the symptoms defined by the Wexner score and anal resting pressure and maximal squeeze pressure. One important aspect is that this investigation, this study, was performed using conventional anorectal manometry. And of course, this is logic because the sphincteric function is just one of the mechanisms that are fundamental for maintaining continence. The Royal London Group performed a test comparing conventional and high-resolution anorectal manometry in patients with fecal incontinence and healthy volunteers. And the slide shows the results for the high-resolution anorectal manometry. And again, only 30% and 20% of patients with fecal incontinence had abnormal values for resting pressure parameters. Squeeze parameters were able to discriminate better patients with abnormal anal function in the context of fecal incontinence. Around 50% had an abnormal squeeze integral, and 55% of patients with fecal incontinence compared with healthy volunteers had an abnormal high-resolution anorectal manometry contractile integral. The authors found that high-resolution anorectal manometry was able to identify more patients with abnormal anal parameters compared with conventional manometry. And as mentioned before, contractile integral seems to be an interesting parameter, and it's a parameter that summarizes the strength of the contraction during the 5-second squeeze multiplied by the length of the functional anal canal. It seems to be a good discriminant to identify dysfunction of the anal sphincteric complex. Another parameter that the group has identified is that of the cuff anorectal response. You can see on the slide how cuffing leads to a strong increase in anal pressure. And the authors compare rectal and maximum squeeze pressure between nulliparous and parous healthy volunteers and with patients, females with fecal incontinence. And they found very interesting findings. First, a reduced increase in pressure between healthy nulliparous and parous women, so within the group of healthy volunteers. Also, as expected, a reduced increase in pressure between healthy nulliparous and patients with fecal incontinence. This is showed on the graph on the right-hand side of the slide. And interestingly, 50% of patients with fecal incontinence who had normal anal function with the other parameters had an abnormal cuff response. So this seems to be a very good parameter to discriminate anal dysfunction. Endoanal ultrasound is recognized as the gold standard technique to identify problems of a structure and integrity, anatomical integrity of the external and internal anal sphincter. On the left-hand side of the slide, we have an example of external anal sphincter defect associated with anal hypocontractility in a patient with fecal urgency. And on the right-hand side of the slide, we have a very marked internal anal sphincter defect affecting almost 50% of the circumference of the internal anal sphincter in a patient who presented with symptoms of passive incontinence. One important aspect is that there is no manometry measure that predicts the presence or absence of an anatomical sphincteric abnormality, and that is why high-resolution anorectal manometry and endoanal ultrasound are complementary tests that can help to design the best therapeutic approach. Rectal sensation to a slow inflation of a balloon in the rectum is also a very important test to perform. Altered rectal sensation can be due to impaired rectal capacity, compliance, or afferent innervation. Hyposensation is seen in patients with neurological condition, or those who defer defecation, and those who develop an idiopathic megarectum, a large and enlarged rectum. And the clinical consequences are passive incontinence and evacuatory difficulties. Patients who have a hypersensation, so reduced ability to tolerate the distension of the rectal balloon, this is seen in patients with proctitis, radiation, or inflammatory bowel disease-associated proctitis, in patients with irritable bowel syndrome and visceral hypersensitivity, and in patients with rectal prolapse. And the consequence is urge incontinence. And it's an important factor because there is evidence that sensory training can help to improve incontinence symptoms. So we have a group of patients with urge incontinence, so that is the inability to defer defecation, and they can present with one or a combination of some of the abnormalities summarized in the slide: reduced stool consistency, increased bowel motility, reduced rectal capacity or hypersensitivity, reduced squeeze pressure, and disruption of the external anal sphincter on endoanal ultrasound. Regarding the passive incontinence, so these are patients who experience soiling or leakage without awareness. Again, this can be caused by one or a combination of the following abnormalities: altered rectal capacity, lack of awareness, hypersensitivity, reduced resting pressure, reduced function of the internal anal sphincter, and an injury to the internal anal sphincter on endoanal ultrasound. But how real this distinction is in the studies that have been performed in the medical literature. So recently there was a study published this year that reviewed 21 studies comparing the outcome of investigations for patients with both urge and passive incontinence. And the study showed that the maximal squeeze pressure was lower in patients with a history of urge incontinence. However, there was discordant results regarding resting pressure between the both groups, urge and passive incontinence, and no difference in sensation threshold for these two groups of patients. Another studies published last year compare 21 patients with urge incontinence with 25 patients with passive incontinence. Quality of life was worst for patients with urge incontinence. The external anal sphincter defects were more common in the urge incontinence, whilst internal anal sphincter defects were more common in those with passive incontinence. And interestingly, the resting and the squeeze pressure were higher in patients with urge incontinence. This other study compared the characteristic of patients with urge, passive, and combined passive urge incontinence. Quality of life and fecal incontinence score was worst for those with combined passive and urge fecal incontinence. Interestingly, the results of the endoanal ultrasound, external anal sphincter, internal anal sphincter defect, and anorectal manometry were similar between the three groups, and only looked like the rectal capacity was slightly larger in patients with passive incontinence. So it's difficult to so there's not a characteristic manometric finding in these two subgroup of patients. But one important aspect that we're forgetting is that it is recognized that patients with fecal incontinence frequently have associated constipation, and this is probably going to influence the approach for these patients. In this study, only 8% of patients referred to a tertiary clinic with a history of either fecal incontinence or constipation, where it was mentioned in the referral letter that there were coexistence of both symptoms. However, when patients were interrogated, 40% of the patients described that they suffer from both incontinence and constipation, indicating that we are not that good interrogating our patients about their symptom presentation. Constipation, as you know, can be due to evacuatory dysfunction, due to dyssynergia, or structural abnormalities like rectocellular intussusception, but also very severe, but also a slow colonic transit can lead to constipation, and severe slow colonic transit leading to fecal impaction can cause overflow, and diarrhea or soiling. This different phenotype is going therefore to require a very different consideration for adding new investigations to establish the mechanisms contributing to fecal incontinence. For example, investigating the defecation maneuver with an rectal manometry and the rectal balloon expulsion test, which can be supplemented by barying or magnetic defecography and colonic transit study. How, with high resolution anorectal manometry, we can investigate evacuation. There are 4 subtypes of dyssynergic defecation that have been identified or defined with high resolution anorectal manometry, looking at the ability to generate an increase in rectal pressure above 240 millimeters mercury or not, and the ability to relax the sphincter appropriately. I want to pay attention to the type 4, which is characterized by inability to raise the rectal pressure and inability to relax the anal canal. That's the type 4 dyssynergic defecation with high resolution anorectal manometry. How good is high resolution anorectal manometry in distinguishing health from disease? In this study, nearly 90% of the healthy volunteers and 94% of patients with functional constipation had an abnormal manometry pattern. The only type that seemed to be clearly more frequent in patients with functional constipation was the type 4, as shown in the slide. And there's an interesting phenotype, which is being defined as, or named as pelvic akinesia, which is the inability to squeeze during the maneuver to increase anal pressure, and the inability to increase rectal pressure upon defecation, which is very frequently associated with a defecation disorder. The balloon expulsion test is a test that involves expelling, with the patient sit in a commode, a balloon that has been slowly inflated with 50 milliliters of air during a given amount of time. And how is this balloon expulsion test in patients with fecal incontinence? Well, 30% of patients with fecal incontinence have an abnormal balloon expulsion test. And this is much higher in those patients who report incomplete emptying, 60% versus 30%. And incomplete emptying is in fact frequently seen in patients with fecal incontinence. Patients who had an abnormal balloon expulsion test also had reduced rectal propulsive pressures, and they had an increased rectal sensory threshold for first sensation. And the important aspect is the patients with an abnormal balloon expulsion test had higher resting and squeeze pressure than those who have normal balloon expulsion test. And how do they compare patients with fecal incontinence who have a normal anal function, which, as we have seen before at the beginning of the slide, is a proportion of patients with incontinence who have normal anal function, compare versus those with anal weakness. So those with normal anal function have abnormal defecation indices more frequently, they have constipation more common, and they have a higher BMI, whereas those with a weak anal canal function, as expected, they have a final fecal incontinence score which is higher. And what are the characteristics in patients with fecal incontinence with associated constipation versus those who don't have constipation? Those with constipation seem to have a worse quality of life. They have better or more normal anal canal pressure, as mentioned before, and they have more frequently pelvic organ prolapse or abnormal balloon expulsion tests. And those without constipation, they have fecal incontinence score which are higher. And there's a history of parity and obstetric injury during parity more frequently seen. In this study, patients with fecal incontinence, functional constipation, and coexistent symptoms were compared regarding the outcome of investigations. I'm highlighting the difference between those with fecal incontinence versus those with coexistent symptoms. And you can see how an intact internal and external anal sphincter is more common in those with coexistent symptoms versus those who have isolated fecal incontinence. And an abnormal defecography was more frequent in those who have coexistent symptoms. I want to highlight finally the patients who have a history of idiopathic megarectum and idiopathic megacolon, which is frequently associated with fecal impaction and overflow, diarrhea or soiling. This is a group that is more frequently seen in the pediatric population, and the characteristics, the clinical characteristics described in this paper by Cam are those of frequent fecal incontinence and fecal impaction and constipation. When the anorectal manometry and sensation threshold were compared between those with idiopathic megarectum and controls, the important aspect is that there were no difference regarding resting and squeeze pressure, but the rectal sensation was clearly abnormal with very marked rectal hyposensitivity due to the enlarged rectum. So we have a phenotype, which is that of fecal incontinence with associated constipation, which has less severe fecal incontinence scores, but worse quality of life, abnormal defecation maneuvers with abnormal balloon expulsion test or defecography, increased rectal capacity, particularly in patients with megarectum, rectal hyposensitivity is frequent, and they have less severe anal pressure abnormalities. So in summary, there's a remarkable results overlap between different fecal incontinence subtypes regarding the outcome of investigations. High-resolution anorectal manometry and endoanal ultrasound are important tests in patients with isolated fecal incontinence, and certain new parameters for high-resolution anorectal manometry can be helpful identifying anal dysfunction. But identification of coexisting constipation is fundamental for the diagnostic strategy because it requires the implementation of other techniques to determine the mechanisms contributing to the symptoms. Anal pressure are less affected in patients with coexisting constipation, whilst defecatory abnormalities are more frequent. Correlation between the subgroups of fecal incontinence and therapeutic strategies is the next step in improving the management of this condition. Thank you for your attention.